I'm going to start my small talk with just a case first. So, 23-year-old male is brought in by EMS for altered mental status. On exam, he's febrile 104, diaphoretic, pale, radioreflexic, and he has severe lead pipe rigidity. So, what are the differential that you all? What are some differentials that you all think of? Right. Serotonin. Yep. And what are some others that sometimes can be mistaken for, like, if you didn't know he had a psych history, if you had no idea his past medical history or meds he was on, what are some other medical conditions or syndromes that you could maybe mistake for NMS or SS? Yeah. What else? Okay, yeah, like rigidity, tox. Okay, what are some other toxidromes? Yeah, so metabolic encephalopathies, like you all mentioned, thyroid storm, and then CNS infection, sepsis, other syndromes like toxidromes that can kind of almost initially be mistaken for, right? Right, and then can anyone say what anticholinergic toxicity, what the one differentiating? Right, okay. So today I'm just going to go through, so basically I chose this topic because I always get these two confused, and every time they come up I never really could figure out which one was which until I thought about it. And then on neuro there was actually a case, and it made neuro more exciting. So then I did a blog post, and then I'm just going to share what I learned on it. So basically just three main objectives. Just to differentiate clinically the clinical exam findings that can make you think of NMS versus serotonin syndrome. And then basically when they come into the ED, some of the pitfalls of using it, let's say, so there's a continuum of their mental status. They could be agitated or they could be comatose. But if they're more agitated, our initial inclination might be to give Haldol and Ativan. So I'm going to talk a little bit about some of why that could be dangerous initially when you don't know what they have. And then at the end, I'm just going to briefly go through some of the major treatments and the use of when we hear of ciproheptadine or dantrolene, and what we should actually be focusing on in the ED and how we treat it. So I'm just going to go through initially with some of the main physical exam findings that there's really just four. So there's a lot of overlap, and later I'm going to show you a Venn diagram that kind of goes through the most important, the overlap and then the differentiating factors. So what of the two, which one does this go with, NMS or serotonin syndrome? Does anyone know? Take a guess. So this one, normal pupils, usually NMS. You don't see dilated pupils. And so serotonin syndrome, you're going to see dilated pupils. And then does anyone know when you see diarrhea, vomiting, which one that goes with? Right. And then, okay, so I'm just going to show a quick video. We'll never do this in the ED usually. It's usually...
this video will introduce you to clonus.
So this is probably
Clonus
the
is
most
when it is
boring
seen in upper motor neuron lesions
part
during
of neuro,
spasticity of muscles and spasticity of nerves. To perform
I'm
the
going to
clonus
summarize
test,
it. So really, I had no idea what this was. And I still don't. But honestly, sorry. So on neuro, really usually they're just putting the foot in dorsiflexion, and then they're watching for plantar flexion constantly and some tremors. So that's really what they're, what is the mechanism for how that works. But does anyone know what this goes with, NMS or serotonin syndrome? Okay. Right. And that's probably one of the most tested clinical exam findings, because it's really specific to serotonin syndrome, and even the other differential diagnoses, usually myoclonus is not present in a lot of those other initial differentials that we talked about. So this is just kind of a summary. really, all the physical exam findings can be broken down into like neuromuscular dysfunction, and then cognition, and then autonomic instability. So of the overlap, you're going to see neuromuscular rigidity in both, actually. It's not just lead pipe rigidity in NMS. You're going to see that, you can see that in both. And then you're going to see like autonomic instability in both, hyperthermia, a lot of that's overlap. And then cognitive changes, you're going to see altered mental status, can go from agitation to coma. You're going to see that in both. But the real, like, some of the main, like I just mentioned, to summarize, you're going to see myoclonus and serotonin syndrome, hyperreflexia more in the lower extremities and the upper extremities in serotonin syndrome, and then the hyperactive bowel sounds, and then the dilated pupils. In serotonin syndrome versus NMS, you're going to see decreased reflexes. Bradykinesia really is what you would say for NMS, and then hyperkinesia is serotonin syndrome. And then just go through. Okay, so another thing that can tip you off to one versus the other is actually the timeline. So serotonin syndrome usually is if you, it's like within 24 hours of starting a new agent or changing an already, like a medication that's already been given. Versus NMS can go, it's like variable timeline of presentation, 1 to 3 days. And then response to treatment is actually kind of parallel to how it begins. So serotonin syndrome is actually going to probably clear up faster when you stop the offending agent, and then NMS can take longer to clear up. And then just to go through, this is like, I'm not going to go through all this, but there's a really good paper that kind of summarizes the overlapping features and then the differentiating features that we already talked about. So the hyperkinesia for serotonin syndrome, and then the bradykinesia for NMS. Okay, so a little bit about treatment. In the ED, we're just really going to be focusing on supportive care. So for both of these, they come in, we're not really going to know the diagnosis right now. We're just going to make sure, so number one, low threshold for intubation for these patients, not just for airway protection if they're like the GCSB or guide, but it's not just for that. With hyperthermia, paralyzing can also help with the hyperthermia to decrease the rigidity, and then to also act as like an indirect cooling measure. And then external cooling, so cooling blankets, but really stopping the drug, and then the supportive care. And then, so this was actually a case on neuro. We had a patient upstairs that a lot of the time these patients probably have both. And sometimes with all these agents, they could be presenting with features of both. And there have been cases that have shown patients that have come in with actually presenting with both at the same time. But to be safe, you should really be using Ativan and not Haldol for the agitation component when they come in, because Haldol can exacerbate NMS, and Ativan is really going to be safe for both. And then other than that, the other medications that you hear of for serotonin syndrome, using cyproheptadine as a serotonin antagonist, that's not going to be unsafe to use if you're not sure if the patient has NMS or serotonin syndrome. So you can give that. Studies there's not enough out there to show whether or not that's really helping. It's just going to help the symptoms, and then more studies need to be done to prove whether or not that's actually helping. But that's not going to hurt if the patient has NMS and you give that. And likewise, dantrolene, if you give that for NMS, it's not going to hurt in serotonin syndrome. But some of the other drugs like bromocriptine, that's also used for NMS, can hurt in serotonin syndrome because it has a serotonin agonism component. And then chlorpromazine is sometimes used for serotonin syndrome, and that can actually make NMS worse. So it's just knowing in the ED, just supportive care and knowing what not to give to make it worse, really. So summary, they really present similarly, and with patient on multiple psych meds, it's really difficult to differentiate. So to be safe, just don't give Haldol. Ativan is safe in both. And then supportive care, stop the drug, intubate if needed, cooling measures, consider cyproheptadine and dantrolene. And then later on, that's kind of when, like, they'll, clonus comes in. That's when upstairs they spent like hours doing the testing for clonus. And it was interesting. Still probably couldn't do it, but it's, but yeah. Does anyone have any questions at all? Yeah.
So dantrolene, when you do your tox rotation, a lot of them will talk about how dantrolene is not the antidote for NMS. It's the antidote for malignant hyperthermia.
Okay.
Right? And then just
Yeah.
mechanistically, it shouldn't work for NMS either. The other thing is, cyproheptadine, you have to remember, is peel only. Right?
Okay.
So if the patient who's taking serotonin, they have to be able to take the other medication.
Okay, thank you.
So I don't know if it was probably might have been the same patient. I think it was after Beth first saw them, and they got like brought over to CCT, intubated, sent upstairs, and then they were actually allowed to AMA from intubation, and then I got them again when they came back to the ED, and they had really crazy clonus. They were hyperreflexive, both upper extremity and lower extremity clonus, like ocular clonus. And we were just redirecting them and giving them benzos to relax them, admitted them, and then again medicine from the ED allowed them to just aim it.
Oh, so that was the guy, yeah, I think that was the one that upstairs when it ended up, I think they were thinking it was more serotonin syndrome. Is that what you all were thinking
Yeah,
too?
that's what he looked like in the ED.
Right.
Like,
And he
the
was
second
on,
time around.
yeah, and they, right.
He kept aiming, and I think there was a question whether he really has capacity to aim
Yeah.
So I've had a couple of these cases too, these sort of catatonic syndromes. And one, I mean, yes, definitely want to consider intubating these patients if you think there is an airway issue, but I do think maybe trying things like waveform capnography. We just had this lecture on procedural complications, right? And having patients on ventilators and developing pneumonias and stuff down the line. They don't all need to be intubated. So I think waveform capnography can help you determine whether or not the person needs an acute airway intervention. Another thing too, benzos can help diagnostically as well, because you can try that, see if you get some improvement in either rigidity or if the patient is having myoclonus, to sort of help you differentiate whether this is catatonic syndrome attributable to those things that you mentioned, NMS and serotonin syndrome, versus other neurologic emergencies.
Yes, Dr. Gresham.
So I've seen a bunch of these, particularly NMS in the Philippines. For some reason, they had a lot of it there. And I saw serotonin several times they linked in that. The most important thing I think you emphasize is really support. Making sure they have enough fluid, cooling them, giving them the benzos, making sure there's not an underlying thing like an underlying infection, stopping the drug. And most of them will do well. Yeah, you can try bromocriptine with NMS, and you can try cyproheptadine with serotonin, but really support and benzos are the way to go. And I have had no deaths from them, and saw a bunch of them, just with those things.
Okay, thank you. Okay, thank you for your attention.